I'm going to switch gears a little bit. So Scott's on here, but I want you to introduce Rich Kruse. Rich actually is maybe one of the most experienced fracture people in the region. He's been doing fracture clinic at the AI DuPont now for 15 years? 20? Okay. So we're going to add him as our panelist. I have a couple cases that are sort of a little extreme-ish, not crazy, to illustrate some other points that are sort of, I would argue some of them are newish ideas. So here's our first case. This is a 14-year-old boy who was tackled playing football. He has a posterior hip dislocation. Rakesh, you want to jump on this one first?
Sure. I mean, clearly he has a left hip, posterior hip dislocation. I mean, the concern is obviously injury to the femoral head or acetabulum. I mean, clearly, emergent, relocation of the hip, the trauma bay or the ER.
So that's always a question. So you just mentioned that first sentence you said. So concern for fracture.
Correct.
Right? Do you do any kind of surveillance before you do your reduction to make sure there's not a fracture? Do you do fluoro? Do you do CAT scan? Or do you just pop them up and then do your follow-up imaging?
We usually reduce them and then get follow-up imaging.
Yeah. So how do you do the reduction? Do you do it, you said in the ED, do you give them sedation, I assume?
Yeah, usually, if it's a polytrauma patient, they're usually already, most of the time already sedated. But yeah, otherwise we get the ER staff to help us sedate the kid, get up on the bed, flex the knee, and just pull on it.
Yeah, and I think most of us would do the same. Now, here's what we're learning from a couple cases that have been published lately in pediatrics. So this is what happened. Okay. So what happened there, Rakesh? Can you see it?
Looks like, I guess while they were pulling on it, they broke the femoral head.
Yeah, so there has been 2 cases reported now. It's actually a physeal separation. It's a Salter-Harris 1 is what it is. And in our meetings, at least, everybody's jumping up and down, like, what do we do now if we have these adolescents who with open growth plates who have potentially, or at least we have no way of knowing if they had a physeal injury with their fracture, okay? So, Rich, in your hospital, are you guys doing what Rakesh did, or are you guys going to the OR? Did you change protocols in the last 5 years since we've been talking about this?
Can you go back to the original film? Is this on? Is this on?
Check them.
You hit the button, maybe.
There we go. Is that on? Yeah. Well, you can't really tell it there. You don't have any other views. So, I mean, just looking at the x-rays, we don't do anything differently. I mean, I'd recommend the reduction. I wouldn't do anything initially. You try to look at the physis to see if you see a fracture. I was particularly looking for a femoral neck fracture myself. I wasn't looking at the physeal head. The one thing we have changed in this, and not in this age, but in the kids who are in the peripubertal when the triradiate cartilage is open after the reduction, I recommend an MRI on all of them, not a CT anymore. I've changed that. Because in these now, it's been well reported in the JBJS that there's a lot of osteochondral fragments or chondral fragments from the labrum that are pulled in or pulled off in the joint that can be repaired. So later labral injuries have been missed in a lot of young kids, particularly in the peripubertal time period. So all these get an MRI now after reduction. Now it's that physeal thing. I wouldn't have done anything differently.
So I'm making the argument that maybe we should start thinking about doing either a fluoro before we put them in, though, or doing them in the OR if you can.
Yeah.
So what do you want to do, Rakesh? Just out of, what are you going to do? This is now transferred to you from the local ED.
Yeah, I mean, you'd want to find out exactly what's going on. I mean, at first, after you do your standard, physical examination, make sure, his neurovascular status is okay. I mean, you'd want to get additional imaging. So, in a 14-year-old, we would, same thing. We would get, all 5 views of the pelvis and get a CAT scan.
Okay. What surgical thing you want to do now?
The big question is an emergency now?
Is it?
That's the question.
It is, right?
It's an emergency.
Does anybody think it's not? Yeah, I think you're right. I think it's an emergency. How about that? You like that? Good, bad. How do you open it? Rakesh, do you do anything differently because he's a kid than you would if it was a femoral neck fracture in an adult?
Yeah, I mean, you'd want to get into your anatomic reduction. I'd definitely open reduce it. But I mean, do we have any? So this went to the OR without additional imaging, really?
Yep. Yep.
Okay.
Well, it is an emergency.
And they did this, and what do you think is going to happen? What are you going to tell the family? This is the only piece, right?
AVN. Yeah, AVN.
Yeah, AVN's high. This kid actually didn't get it, but AVN risk. So AVN is usually a complicated problem in this age group because you're left with not a whole lot of great options, right? All right, let's skip. So there he is in 2 years. They got lucky, right? I always think they got lucky it just happened, right? Your favorite, how about this one? So another complicated problem with us, with our system, as you got in our world, as you know, is what to do with the proximal humeral shaft fracture, really these proximal humerus fractures. So, Rich, you want to take this one? 9-year-old girl, ATV accident.
Yeah, I'm assuming it's an isolated neurovascularly intact injury.
We'll say it's isolated. I think she had actually a compression fracture in her T-spine or something, but yeah.
Nothing in the upper extremity that it would affect.
No.
So, okay, so treating it as an isolated fracture.
So what do you see first? Describe that, because is that common to see this combination in a 9-year-old? What is it?
I see the completely displaced proximal humeral metaphyseal fracture.
And how about the joint?
And the joint is dislocated, which is uncommon. I mean, seeing those is extremely uncommon because usually you get a metaphyseal fracture without the dislocation, but
Yeah.
that's uncommon.
Yeah, it changes everything, right? Well, not it changes everything, but it's a fascinating combination. I think I used to say I've never seen a dislocated shoulder in a kid with open growth plates who didn't have hyperlaxity, right? They almost always get a metaphyseal or a physeal fracture of the proximal humerus in the same mechanism that dislocates shoulders in older people. All right, Rakesh, what do you want to do? Vascular status is fine. She's cleared for the OR. What do you want to do?
I mean, you can try, if you're lucky, and try and close reduce that. I mean, it's not unreasonable to try and give it one shot. Put your fingers.
So you close it and then what?
Try and put your fingers in the armpit and try and push. And
good. And what would you do after you close reduced it?
depending on what it looks like. I mean, you could close reduce it, and if it looks okay. I mean, I've heard another person that you can make an argument to allowing it to heal, but another option would be to pin it.
Yeah, good. So actually, that's exactly what this was done here. They did a close reduction and got the shoulder joint reduced, and then they did as best they could to percutaneously pin this. So I said as best they could. Have you done these?
I've done 2 or 3.
Are they fun or not fun?
They're miserable.
They're miserable. I would agree. They're very difficult in a 9-year-old. I think they're difficult in anybody. But what do you think of the reduction? Reasonable?
The image on the right looks like it's in. It's hard to tell, but
It's hard to tell.
I mean, for a pediatric patient, maybe it's okay, but
Yeah.
that's not.
What are acceptable parameters? Rich, for acceptable parameters for reduction of a proximal humeral metaphyseal fracture in a 9-year-old?
The indication for operation in a 9-year-old is almost non-existent. So in this one, I would have contended get the shoulder back in place. That's critical, and that you would do straight away. And then almost any humeral fracture, even 45, 50 degrees, even more, I accept.
Great. So they did accept this, and this is what it looked like 6 weeks later. So it healed, and there it is 3 months later. Is that going to remodel, you think?
Yes.
Yeah.
Yeah. So the indications for a 9-year-old with this fracture are almost non-existent to do fixation. I shouldn't say almost, but this is one of the few times I might even consider it, only because of the dislocation. The remodeling potential for this is almost infinite, as long as, my caveats are, you can't have the metaphysis higher than where the greater tuberosity is ossifying, okay? And then you could have 100% displacement, I'm fine with that, but you can't have more than about 40, probably 35 degrees of varus. Okay, there have been some malunions of fractures in older kids that don't remodel, that wind up with a loss of abduction that need to have osteotomies. It's been described, but it's not common. Okay. Any other comments?
Yeah, it just seems that we're getting less and less aggressive on the proximal humerus, and this is one fracture I see in my practice almost on a daily basis that's overtreated and too much worry generated on the part of the parents that you have to have an operation using adult principles applied to children. It just doesn't work. You know, the old teaching was 50-50 at age, 5 or so, you get 50%, or 5 or 6 years of age, you get 50% displacement, 50 degrees angulation. Other than that, you need a reduction, but that's clearly too low. You don't need to operate on these almost, other than what Marty said. Over about age 12, the decreases in remodeling tend to go up. So over age 12, we worry about them a little, but it's still unclear as to which ones need operations for sure.
Questions? We're going to stop. So questions from anybody about any of these?
This is the female, yes?
That's a girl, 9-year-old girl.
So suppose she's showing secondary sexual characteristics. Wouldn't change it?
The growth plates are open.
So that's the classic question, though, right? How do you judge that? Because we have that problem a lot, and especially if you work in an area where I do, where the Hispanic girls are skeletally mature at 11. So this has open growth plates, but if you had any doubt, you could do bone age or Sanders age or something. But it's a question. Honestly, it becomes more of a question depending on the population you take care of. So you have to adjust that, and you have to kind of look at the growth plates. If the growth plates look like adult growth plates, then you have to switch your algorithm.
Yeah, and interestingly, in the paper that they did look at, the one, it's poor data. Over age 12 is when they're saying you start to have to consider straightening it out a little bit, but they used chronologic age. They didn't use bone age.
Marty, I wanted to ask you a question about one of the cases from before about your femur fractures. You talked briefly about those tweeners, the kids who are adults but not really. They're sort of 15, 16, 17-year-olds who have these femur fractures. Is there any role in those patients that for retrograde femoral nailing? This is a discussion I've had with some of my partners, and there is some disagreement whether retrograde femoral nails in that patient population. I mean, do you take into consideration what the gentleman said earlier, like
Totally.
the Tanner classification or anything like that before?
What he said. Well, is there literally, like, if you think there's 2 years of growth remaining, you can't do it.
Right.
And if you can't tell, you can't do it. Okay, because you know that physis is done, right?
Right.
So I'm fine with the 17-year-old, right, because you know that kid's not going much.
Right.
But there's that 15-year-old boy
Right.
who barely has his voice changed. I think you can't take the risk. I really don't. I mean, you can have the discussion, and if it's the only thing you have as a bailout to choose for that fracture, then do it. But then the next discussion should be when you're going to do the epiphysiodesis on the other side or something.
Really?
Yeah, you have to be clear that currently open growth plates in the knee are contraindication to retrograde femoral nailing.
Thank you. I think we're done. Thank you.